Good morning, everyone. I am Antoine Vieillard-Baron, and I am really happy to show you some slides about the hemodynamic monitoring in acute respiratory distress syndrome, and I will mostly focus my presentation on RV failure detection. I do not have any conflict of interest. Just to remind you that the hemodynamic failure in this disease, in this syndrome, is very high, around 60 to 70%. Could be related to sepsis, but something that I will not discuss today, but mostly to pulmonary hypertension and mechanical ventilation strategy. We know in the literature that this is also strongly associated with prognosis and outcome. And finally, in many cases, this hemodynamic failure, except in case of sepsis or septic shock, is related to RV failure. So I will just focus on three main parameters. The first one, which is the pulse pressure variation, so requiring an invasive blood pressure monitoring. The second one, the CVP. And the third one, of course, the echocardiography. As you know, you may also use other devices as the pulmonary artery catheter or the transpulmonary thermodilution, but with many limitations in this specific situation. So first, I will present the CVP as the suspicion of RV failure. So CVP should be used, and probably I will say now must be used, as you know that when the CVP is high, you may suspect indeed RV failure, and you know that I will discuss that very quickly. Transmitted pressure, the transmitted pleural pressure. So why CVP, which is a continuous monitoring, is very giving you a suspicion of RV failure? Because we know that RV failure is related or is associated with signs of systemic congestion clinically, but also indeed, if you look at the CVP is very frequently elevated in case of RV failure. And if you look at this study, very interesting, it's not at all RDS, this is advanced decompensated heart failure, and the congestion was evaluated as the worsening of renal function. And just look at these 2 points, this is here the filtration, the glomerular filtration rate, just to show you that despite the high cardiac index indeed, compared to the low cardiac index here, the worsening of the renal function was much higher when the CVP was increased compared than when the CVP was not increased and remains low. And here in this study, a low CVP meant that the CVP was at least below 8 millimeters of mercury. One limitation, as I told you, when you have to control and monitor the CVP, is the fact that if you increase, for instance, the intrathoracic pressure, here in this study in animals by increasing the PEEP, this is a PEEP trial, you know that you may just observe an increase in the CVP, or here the right atrial pressure, because of the transmission of the pleural pressure to the right atrium. And you can see that in the same time, the distending pressure, so the pressure which is more related to the amount of blood into the right cavities, did not increase. And so this is clearly a potential pitfall in this approach. Here you have an example in a patient ventilated for acute respiratory distress syndrome. You have the right atrial pressure, the CVP here, the esophageal pressure here, and look at that during TADI ventilation, indeed the right atrial pressure increased. So first, apart by transmission of the pleural pressure, but if you look at the distending pressure, which is the right atrial pressure minus the esophageal pressure taken as a surrogate of the intrathoracic pressure, you observe that in the same time it was also related to an increase in the transpleural pressure, so more blood into the right cavities, and so some part of right ventricular failure. So be aware that indeed in some situations, sometimes the increased CVP is not always related to more blood into the right cavities and so to RV failure. could be just related to increased pleural pressure. But if you want to avoid this pitfall, you have to insert an esophageal balloon, so into the esophagus, to monitor also the esophageal pressure. And you have another example here in a patient, ARDS patient with COVID-19 under pressure support ventilation. You visualize here the change in the esophageal pressure because the patient was able to promote the inspiratory cycle. So look at the huge decrease in the esophageal pressure during each inflation, and you may assume that it was transmitted to the CVP, so underestimating the true, let's say, or the transmural CVP. The second point where you may have the suspicion is not the CVP, is also to continuously monitor the risk factors, the clinical risk factors for developing RV failure. And they are very easy to monitor, as this is the pneumonia as the cause of the ARDS. So you have just to look at the admission the cause of the ARDS. But each day or any time you want, is discontinuous, but you may evaluate the driving pressure, the PONF ratio, and the PCO2. And you see that for each of these targets, you have, let's say, 1 point in a score that we built in a large series of RDS for the risk of developing RV failure. So no risk factors less than 10% of risk for developing RV failure. 4 point means a very high risk for developing RV failure. Second, the echocardiography is the confirmation and is absolutely mandatory in this monitoring approach, as it may detect acute cor pulmonale and RV failure, and especially because RV failure may be defined as the excessive use of the Frank-Starling mechanism, and so the RV delays. Typically here in the RDS patient ventilated, you see in green the airway pressure trace. This is TEE. The RV and the right atrium are very dilated. And so you have a typical picture of RV failure. And in this case, we had the suspicion because the CVP was elevated. Why probably this is a little bit limited just to look at the echo, and thus probably we have to combine the echo, so the RV size, with the level of the central venous pressure. Because this is a recent study that we published in Crit Care Journal in many patients admitted for septic shock. All were invasively ventilated, and many of them developed acute respiratory distress syndrome. And look at here the distribution of patients according to the RV size and CVP. And you observed, and we observed here, that 42% of patients finally had RV dilatation on the echo, plus a CVP of at least higher than 8 millimeters of mercury as a surrogate of congestion. And so probably this group is the group which develops RV failure. Third, the pulse pressure variation, which could be considering as a perfect warning signal, and so is absolutely mandatory. It is absolutely mandatory, to invasively monitor the blood pressure to get the pulse pressure variation. Look at here, this RDS patient, significant pulse pressure variation, 28%. Look at the blood pressure. And so you have the suspicion of the bad interaction between the ventilator and the RV. And so probably that some patient may have RV failure. And it was actually the case in this patient with a huge dilation of the right atrium and the right ventricle, so RV failure. Plus, look at, we did not measure the CVP, but look at how was moving the intra-arterial septum bulging toward the left atrium. So high pressure into the right atrium, high CVP. And so typically, when you have this picture of significant pulse pressure variation, you may observe using the echo some RV overload or RV failure, and so to discuss different treatment and management that just giving more fluids in case of this pulse pressure variation is related to fluid responsiveness. And so indeed, you have the hemodynamic strategy, the specific strategy as nitric oxide inhalation, prone position, the respiratory strategy to limit the PEEP, the plateau pressure, to correct the hypoxemia and to avoid too high hypercapnia, but I do not have some time to discuss too much about that, and this is not exactly the scope of this lecture. Just to show you, so to conclude, first, if you have significant pulse pressure variation, so it's a continuous monitoring using invasive blood pressure, or if you have respiratory risk factors clinically, I mean, which is more discontinuous that I show you based on the driving pressure, the P-on-F ratio, and the PCO2, or if you have an elevated CVP, which is a continuous monitoring, you may continuously monitor the CVP through the central venous line. So either you have 1, 2, or 3 of these factors, you may consider doing the echocardiography, just giving you the key information, which is, do we have RV failure in this patient? And if you have RV failure, as you know, probably that you have to apply, as I told you, a hemodynamic strategy, which is not based on more fluids, but probably more infused on the shock, on the respiratory strategy, as I told you, which is to limit the PEEP, the plateau pressure, the PCO2, and to improve the oxygenation, and of course to apply a specific strategy to RDS. And we know now that prone position in this situation is very useful to prevent or correct the RV failure, and finally to increase the outcome and improve the prognosis. And I thank you very much for your attention.